Welcome to the Interprofessional Space podcast, where the spirit of inquiry meets healthcare collaboration. In our podcast, we discuss all things interprofessional education. According to the World Health Organization, interprofessional education, or IPE, is when students from at least two healthcare professions learn about, from, and with each other to improve health outcomes and enable effective collaboration. Tina Patel Gunaldo is dedicated to improving healthcare safety through better collaboration. Years ago, as she helped a close friend's husband navigate a difficult medical journey, she was inspired to expand her focus from physical therapy to teamwork science. Tina has held leadership roles in education, administration, and research. She's authored over 40 publications and 150 presentations and co-edited an IPE textbook. She founded Collaborate for Health, an organization focused on improving healthcare collaboration. Tina is a leader in the field of IPE and serves as the current co-president of the American Interprofessional Health Collaborative. And so we're excited today to have Tina Gunaldo join us. Welcome, Tina.
Hi, thanks for having me.
So tell us a little bit about your journey in IPE.
So thanks for asking that question as well. I'll always say that I dedicate my journey to entering into interprofessional education and now practice because of a colleague who is now a best friend. But approximately 12 or 13 years ago, she allowed me into her life and her husband's medical journey. And it was from that direct exposure and that lived experience where I understood the importance of interprofessional education as well as collaboration. And that's where I really realized is that I think as practitioners, we really do want to work in teams and we have a collaborative spirit. But there are structures within the health organizational system. Structural could be physical structure, it could be regulatory structure that could challenge us in collaboration. And so we need to recognize those and we need to adjust for those challenges so that we can collaborate. But basically, my journey was introduction to a colleague, now a best friend, went on that journey with her and her husband. I was in education at the time. And at that time, at the institution I was working for, we had a grassroots level work group that had then formalized into a recognized committee by the institution and then a centralized office of interprofessional education. And I was in that role as their inaugural director for 9 years. But recently in September of 2024, so just a few months ago, I entered into a health system, helping them specifically in the area of health equity and interprofessional collaboration.
Wow. So I think this interview is going to be, for me, particularly interesting because you really have that both sort of sides is the wrong way to say it, but both views, both lenses is what I really want to say. You know, the lens of coming purely from academia and then from the practice perspective. And I think that's unique. I've certainly not been full-time in practice for quite some time. So I'm really excited to sort of hear some of your insights and things that you're discovering as you move forward.
Yeah, and I just started, so I am learning as well.
So how is it similar because you spent so long in academia? What have you taken from your time in academia and then when you're moving into practice? And what have been kind of the first things that you've noticed that are different or similarities?
So one of the things I see is different. So I am starting, this is a health system, and so they have inpatient settings as well as outpatient settings, clinical settings, and it's spread out, right? It's not just on one campus. And so one of the things I've started on inpatient because that is where the need is at this time as related to health equity work that's required by CMS and by the Joint Commission. And so from an inpatient perspective, we don't have to, the team does not have to convince anyone that we need to work together. And so I think that's a difference. And so probably most of our students, unless they've had a personal lived experience with themselves or with a family member or a loved one or friend, they have maybe not gone through the healthcare system and seen it from a collaborative side. So it's just like you and I, if we go to our annual visit, we see our optometrist separately than our dentist, than our primary care provider. And on inpatient, because while I know some people will talk about, are they really teaming? But at least they're physically surrounded by one another all the time. And so you're not trying to convince them that it's best to come together and collaborate and have a discussion. So I would say, whereas when your students come together, they enter in through, right, their general orientation for the institution, but then they go into their orientation of their school and their program. And then, generally speaking, interprofessional education is introduced after they've become acclimated to some point, whether that's weeks or months or years before they enter into their first interprofessional education experience. And so they've been learning in silos, maybe in a multidisciplinary fashion, but still basically in a siloed arena. And then we're asking them to come together for interprofessional education. And so while their co-location might be there on one campus, they're not continuously passing by one another, asking simple questions of, hey, can I go in and see the patient right now? Are they stable? Right. So simple questions like that. So I would say that's the biggest difference, is that there's no convincing as of yet. So I'll just say that to have people collaborate together, they're not asking the why. And I feel like students always wanted to know the why.
That's an excellent point. I feel like if certainly in my experience with IPE, I don't necessarily hear the students say that out loud, but the interactions make me think that they're wondering why, or alternately, that they're there to just tick a box and they're not valuing maybe the experience that they're about to have as an early student. Um, so that's great that you don't have to sell them, right? They're
That's right.
already, that's fantastic. So I guess following up on that, I know a lot of your work, or the what I see you post and share on social media, talks about the importance of the patient as a team member and family members and their perspectives. Um, can you talk a little bit about how you're seeing that happen, or maybe not seeing it happen in your role now, and what steps you're taking to maximize that? Because I know from, again, what I've read and I've heard you say, that I know that you believe strongly that that's important.
Yes. So I think in every health system, right, resources are allocated as needed. And so at the particular health system that I work at, there is a patient family advisory council, and they have quarterly meetings, which is great. Um, and so I've had the opportunity to attend two of those meetings, and I've had the opportunity to engage patients and families and carers within those meetings and ask them about particular projects. So, for example, just last Friday, I was able to show or demonstrate our new community resource list that we've developed for our patients. And best practice would have been someone would have been on staff or employed with the health system, always sharing that patient lens or that family lens. And so they're with you along the project or the development of the project. But in this case, that didn't happen, but that's okay. So, but at the very end, after the community resource list had gone through all the multiple professions to take a look at it, to contribute to the external organizations, to contribute to the information through marketing and how it visually looked, we were able to show a draft to our patient family advisory council and ask their thoughts. Was the font size appropriate? Was it easy to read in terms of language? What did they think of the colors, right? The boldness, lots of aspects. Did they find the way we developed the community resource list to be more patient centric? And so the patient community resource lists that were utilized here at the health system before were great. They were at least something. But if you looked at them visually, it looked more like a phone book. And so we want individuals, if they're going to go out into the community to access these external resources to support their health, we want to also set up those patients for success and attaining or being able to sign up for those resources. So, for example, as I was talking to food pantries and food banks, I asked them, so what stops a patient or a community member from not being successful in signing up and to be able to receive food when they come to your facility or your organization? And the one thing that was always a challenge was that that individual, that community member needs to come with a photo ID, needs to come with some type of proof of residence that they're living in Louisiana, which would be a parish, but in most other places would be counties or regions. And they need to have some type of letter that indicates their income level. Well, if you're seeking food because you have some type of food insecurity or food need, you're not thinking about the documentation you need in order to successfully sign up for those monthly food boxes. And so on our community resource list, in addition to the name of the organization, the phone number, the website, the address, we've also now included items such as, in order to be successful or in order to, sign up for a food box, please bring with you your photo ID, your proof, a utility bill, your food stamp letter or your income letter. And so then that way they know what they need to bring once they're discharged from the hospital or they leave that outpatient visit. They know what they need to bring in order to be successful when they engage with that particular community organization. So I kind of took that full circle in that, how do we engage patients at our particular institution? It is through our patient advisory council. But I will say, because I very much believe in getting patients involved, when we do meet as a team of health professionals, I always make a remark. Okay, let's all put our patient hats on. What should we be seeing now in these community resources? And so we're all somewhat of a patient at some point in time, even if it's not currently while we're working through this project, but we take a pause. Everyone take a look at this from a patient perspective. What are your thoughts? And so those are the things that we're doing to help support patient engagement, patient-centered care, putting the patient first. I hope that's helpful.
I noticed on a recent social media post, you talked about your work in establishing a hospital-based food pantry, and you pointed out, and this is so impressive, 15 internal departments and 13 external organizations. Do I have that right? Are involved. Tell us about that. Where did that come from? Obviously, that's interprofessional, and so yeah, I would love to hear more about that.
Okay, I'll try to make it short. So it was, it took 15 weeks to pull this together. And so before I start on talking about that story, what I do want to mention is that if I didn't have the exposure to interprofessional education and if I wasn't a big proponent of team science, and so integrating the science of how we can best work together in teams into my work or into the work that I do, I don't believe it would have been 15 weeks. I believe it would have been longer. So it is so important for everyone to know that that development of that interprofessional lens, development of that interprofessional identity is real. And it's not going to be a one-time experience in interprofessional education that might get someone there. Of course, it might spark an interest, right? Or some motivation, but it really will be the continuous interaction with other health professionals and building that lens, building that knowledge of what someone else does, building that level of respect and valuing their expertise to really come together collaboratively. So, long story short, is that I am also working in health equity, like I mentioned before. And so, one of the things that hospitals are required to do in the United States is address health related social needs, or some people will call them social drivers of health, but it's actually health related social needs. And so, they're required to ask patients about 5 domains, one of them being food. And so, over the year, even though I was just hired in September, the hospital was asking their patients, their inpatients, about their food needs since January 1. So when I came here, I looked at the data, and food was the number one need out of transportation, housing, utilities, and intimate partner violence. So it was with my boss and a team of us who said, because I am situated within the quality department. I guess it's a good way to organizationally structure what I'm doing. And so within the quality department, there's a larger team. And so understanding that we have patients that have needs surrounding food? And then what can we do it as an organization? And so we thought about it and we said, well, what about a food pantry? And so there was an initial meeting, and I actually just plotted this out because we're going to actually have a meeting, a subsequent meeting. But we were able to do this in 4 meetings. And in all of those meetings over the past 15 weeks, our team grew. And so one of the things that, going back to your question, Susie, or just kind of your comment, or what are similarities and differences, is a difference would be when you're creating an IP experience, you try to get everyone at the table to create that experience of who might be involved at any point in time in that patient's journey, right? Because it's for that one-time experience. Here, we started with a group of people who we thought we would need to be involved, and then we grew the team as we saw necessary and as we learned more about what we would be doing in regards to a food pantry within a hospital. So as you talk to, your counterparts in other hospitals, you learn more. As you talk to internal departments on what is their role here at this facility, because I'm new, so I'm still learning. So we added on as we went along. So those 15 internal departments, that was not what our first meeting looked like. It will look like that when we have our follow-up meeting at the end of the month. But we were able to do that over 4 meetings of gatherings. And then obviously we had small working group gatherings throughout. But it was working, honestly, it was having at some point, I will say this, I did notice that you can come to a meeting and you can listen and get updates on what's happening with the food pantry or what needs to be done. But one of the things that I did differently at one of the meetings was that when the meeting first started, we went, besides a welcome, we went around the table and we asked everyone to share their role as it was related to the food pantry. And so that gave them the opportunity to share their perspective and also their role on what they were doing. So I could learn what marketing was doing. I could learn what pastoral care was doing or thinking. And even though I took the lead on it and I was having side conversations with everyone the entire time, not everyone else on that team, right, got to hear what the registered dietitian was thinking when they were developing recipes and food products that should go in those bags. Not everyone understood that how pastoral care could possibly be a part of this team initially. And marketing, how did they see their role, right? Because they're not giving the food bag out to the patients, and so they're not patient forward facing, but they definitely have a role on the team. So I think what I've appreciated about developing a food pantry from an interprofessional collaborative practice lens is that it has been internal departments, it has been external departments. You learn as you go, you invite people to the team, you catch them up, because I want to say one of the things that you need to do is catch new team members up. So that's really important so that they share in that shared goal. They feel like when they come to the next meeting that they're a part of that team. And you need someone to do that. And so the last thing I'll do is advocate for, I think, every health system is that if you're going to encourage your professionals to work in teams, they really would benefit from having a team manager. And I think that is so important because I think adding what I just did on top of anyone's job would have been very difficult to do. And the collaborative piece may have not seemed as collaborative as more of a top-down process that needs to happen or project that needs to be developed. Is that helpful? I know that was a lot.
Yeah, no, I mean, that was great. I think I also feel like that sometimes, I think what you're talking about, the manager and the person that's kind of organizing or running, leading the team, really. But it's so undervalued sometimes. I think sometimes, especially like that, they're like, oh, just throw it all together, just get the people together and do it. But to do it well, I think you do have to. I think that's also behind you. You talk about the team science, and that seems to be something that you're very passionate about. And that's really an expertise of yours. Is there anything that you want to share along that? Because I know that's also part of the IPEC core competencies and something that we really strive to develop in, from an academic perspective from students, but, obviously that needs to translate into practice as well. So I guess any key things relating to team science and any tips?
Yeah. So I would say that I used in education, I used the IPEC competencies as well. So the US IPEC competencies to help guide curriculum. It was something that I thought was very important. I was very excited to see in the most updated revision that in under teamwork, I believe this is true. Now, I haven't quite looked at them as frequently as I used to look at them in education, but I believe it's true that one of the teamwork competencies or sub competencies is related to the science of teamwork. And I was thrilled to see that because I think that is one thing as educators we need to integrate into the way we develop our curriculum. So we need to integrate those team science concepts. And so um, when I was in education, I had the opportunity to read a lot of research. I would say that's the one big thing that I miss a lot when you leave an academic health sciences center or an educational institution. A lot of hospitals don't have access to libraries. And so sometimes we wonder why there's a gap, in education and practice. Well, these people in practice don't have access to a nice library to read the science, the evidence-based science. And so they're depending on their annual continuing education, right, events to give them that information. And so that's a sidebar. But I think where I'm going with that, Susie, is as I had the opportunity in education to do some reading, do some research, and integrate that into the curriculum, I found 30, what I call are 30 characteristics of high performing teams. Um, I remember listening to Eduardo Salas, which that's where I first really was introduced into team science and the 7 C's of team science. And I believe that wholeheartedly and practice that. That as I start, and those are very global, right? Communication, cognition, conflict. I mean, those are very global terms, and they're all situated within a C. So it makes a nice framework. So where I learned to really appreciate the science of teaming was through Eduardo Salas's 7 C's. And so I don't know them by heart, so I'm just going to read them for a second off my screen. And so the 7 C's: cooperation, coordination, cognition, coaching, conditions, communication, and competence. And so these have evolved over time because I think at first, in one of the initial articles he wrote, conflict was one of the 7 C's. So, but it provides you a really good framework as to what you should embed within your work, whether your work is in education or whether your work is in collaborative, in practice and settings. And that's a really great place to start. But as I started reading the literature and going past healthcare, so right, you have retail teams, you have engineering teams, you have IT teams, you have organizational psychology teams. In all of that literature, they're all talking about the science of teamwork. And what I think is interesting is that we have the evidence as educators and as researchers, we always question the evidence, but we absolutely have the evidence to integrate to help develop stronger teams within our student teams or within our practice setting teams. But saying that, the 7 for me turned into 30. So I have 30 characteristics of high performing teams is what I've developed. It's what I use every day. I think of it as a DJ box, all these dials on there. They're all in neutral. I assume they're in neutral. I assume none of them are below neutral with my team. And then, when something's not quite going right, or you're about to enter a phase of the project where maybe it's going to be speed it up, right? Or maybe you're going to have 3 new people enter your team. Go back to your characteristics, your 30 characteristics, and dial up that characteristic that you need in order to be successful. So, in order for those individuals who were new to the team to feel like they were a part of the team, I had to make sure that they shared our goals already, right? But I also had to make sure that if they thought there was a new goal or there was a tweak to the goal that we needed to make, that we were going to be open and we were going to consider that. And so having that open form of communication, that deliberate communication, spending that time with them and getting them acclimated and caught up was so important. And so that's where I would say I dialed up that characteristic at that point in time. And if something's not going well, there was one time I remember through the development of the food pantry, it wasn't like things weren't going well, but I was like, something's missing. Like, what is that? Like, something's not just gelling quite right. I went back literally to my 30 list and I was like, that's what it is. I'm going to fix that on Monday. And I did, and it got better. And so I just want to say that we as educators, we are so good as researchers and wanting to learn more about interprofessional education and what's going to make it better. But I would say that we need to take some time to look into the literature, specifically in teamwork, specifically in communication, compassion, empathy, right? All of these broader areas. And we need to go into the literature and we need to say, this has already been researched. Yes, maybe it was in a different environment. Yes, maybe it wasn't with healthcare students. But you know what? It worked. There's enough articles that research this concept. You know what? I'm going to take what their findings are and I'm going to integrate it back into my curriculum. And that's what I started to do. So it's trusting that people who have done this work in some way, form, right, that you can take their information and actually integrate it because that is the science. And that's closing the loop. And you might study it in a different way, but there is information out there for us to be more successful. And so when I think about return on investment, because I really think that's an important question for interprofessional education, what is the return on investment? What is it that is going to make one IPE experience just as effective as 10? I don't know that we know that answer yet, right? But your outcome for one is probably not going to be the same outcome for 10. Like, what's your goal for one IPE experience? It's probably to check the box. What's your goal if you can have 10 IPE experiences within someone's curriculum and you can vary the settings, you can vary the team members? That goal is very much different, or that learning goal is very much different than the check the box goal. And so I would say utilize it's always important to utilize your resources that your institution has because that's important for sustainability. But then after you understand what those structural supports are and that you have and that are sustainable, start to think about what your true goal is and then apply the science that's already out there in the literature. I hope that was helpful.
That's very helpful. And are you going to be able to share? I think you had mentioned you'd be willing to share the 30. Uh, they're not C's. I'm assuming you don't have 30 C's, but
No,
you.
yeah, I organize them into what I call the guide. So, and I can't say I remember all of these by heart either, but G is for goals and planning. U has a little bit to do with unity and inclusion. Well, I'm sorry, I is inclusion. Sorry. Um, D is you see, you caught me, maybe development, and then E is really is expertise and excellence. So that continuous improvement model. So, but yes, there are 30 characteristics. There might be more. I only found 30, but I'm sure as I keep reading about the literature, I'm going to find more and I'll add to it, or maybe I don't add to it for a while, but there is a list of 30. Don't let it scare you, but embrace those 30.
I really
I
like that you
think,
used
I'm
reflective.
sorry, go ahead,
Sorry.
Susie. We do this all the time. We
I was
talk over each other.
I know. No, I was just going to say I loved how you used it as a reflective tool. So like where you had
Yes.
an issue and you then went back to it because I think so often we forget to do that. You just think, oh, that was just a bad meeting or that was a bad session, and then just leave it. And but
Yes.
really, it's having but you need tools like that to be able to help you reflect, and I think that's perfect.
Yeah.
Sorry, Anne.
No, please don't be. No, it's great. I agree. I was just thinking, I really appreciated the visual. So if you were going to tell me about this list of 30, it might be a little overwhelming for me, but the idea of the mixing board, that visual, and the idea of using it as a toolbox, I find that very accessible. And that's something that I could see myself using as a tool and referring to periodically, sort of similar to what you said, Susie, in a reflective way. But yeah, that's really interesting. And we'll share that in the show notes, access to that document.
Yes. Okay. I'll send that to you because I think, like I said, I use it because you're not going to always remember the 30. Once you integrate them into the way you work, it becomes easier, but you have to intentionally do that initially. And then it just becomes a habit and it happens. But there are times where I can't remember all 30, even though I'm the one who developed this guide of 30 characteristics. So I have to use it as a tool myself. And it's part of being human, right? We can't know it all.
Absolutely. And I feel like to me, that's empowering as someone who's thinking about picking this tool of yours up and using it. It's empowering to know that I'm not expected to know it all. And even the person who created it, has an opportunity to look at that and think, where can I do better? I love that continuous improvement and that desire to make it better for the team and for the outcomes.
Thank you.
Thank you. That wraps up part 1 of our conversation with Dr. Gunaldo. Be sure to tune into the next episode when we'll talk about Collaborate for Health, as well as the American Interprofessional Healthcare Collaborative and more. You won't want to miss it.
Before we sign off, we want to remind you that whether you're a student, a practitioner, or educator, the work you do is important and can be stressful, but you're not alone. Please take care of yourself, let's look out for each other, and we hope you'll join us again soon.